Good evening, everyone, and welcome to Research CP Dystonia Edition. This is the voice of Paul Gross. I have with me Bhooma, Aravamuthan, and Melanie Brittingham, and we're going to get the program started. You should all be muted, and we will have a Q&A session, but we've got a lot of content to cover on this opening webinar, and so we're going to keep you muted. There is a way to raise your hand or chat either amongst yourselves or with us, but we're probably going to be, if you have problems, please don't hesitate to note that so that we can see it, and we'll try to adjust it in real time. But in general, with this many people, we're going to just try to get through until we open up the floor for questions and answers. Okay, so this is webinar 1, and as I said, this is Paul Gross, and I'm the founder and chairman of the Cerebral Palsy Research Network, and I'm going to take you through our agenda for today. Okay, so what we're going to do is walk through who we are collectively, including all of you, and why we're here, and what we really hope to accomplish with Research CP Dystonia Edition, and then how Research CP as an initiative will achieve our goals. I'm going to touch briefly on what CPRN is, what is a collaborative research network, and then we're going to spend the bulk of our time on what dystonia is, and Dr. Aravamuthan is going to take you through that. Okay, so who we are and why we're here. The group that is online, we've had about 100 people register, and about 65 that are set up to listen to this first webinar, are clinicians that treat people with CP, so doctors and therapists, and researchers, and then community members. And we probably at this stage have more community members, but we're pretty evenly split between either people that are caregivers for people with CP or people with CP themselves. We have patient advocates and people representing organizations that advocate for people with CP. And we really have a number of leaders in advancing research for cerebral palsy, and in particular interested in advancing research for dystonia in cerebral palsy. So why are we here? It's to establish a list of priorities for us to pursue from a research perspective that are focused on improving the lives of people with dystonia and CP. We're also here to build a set of relationships. This is the second round of Research CP that we have run. And what we found is we built a number of great relationships between the broader CP community that is interested in seeing research and care advance, and the committed clinicians and researchers that really want to engage in research and want to do research that is patient-centered, that is important to the patient community. So I'm going to turn the mic over now for a moment to Melanie Brittingham, so she can tell you a bit about her experience and her son's experience with dystonia. She is a member of the board of CP Now, who is our co-organizer in this. And so, Melanie, I'm going to see if I have to unmute you, but once you see if you can speak, I think you can.
Hey, Paul, can you hear me?
I can.
Perfect. All right. Hi, everybody. As Paul mentioned, my name's Melanie Brittingham, and I am super honored to be a part of these events this evening, mainly because my first role and most important job is mom of 2 children, one of which has cerebral palsy as a result of HIE, or an oxygen deprivation injury at birth. So as a result of that, I'm Austin's #1 fan, and I'm also a member of CP Now and a parent advisor to CPRN, because these are organizations I am proud to be a part of. I know the work they're doing is making a big difference. I also serve as a representative on UVA's Child Development and Rehabilitation Center, providing guidance to UVA on their new children's hospital on issues such as accessibility, inclusion, and awareness, as well as some fundraising. And I'm pretty passionate about the topic that we're covering here this evening, because I believe that my son suffers from it, and I also have a broad network of friends and fellow moms and dads and other community members, people with CP as well, that suffer from this as well. And I think it's really an underserved area. So Paul, if you could go to the next slide. Why dystonia is really the question that I hope to provide some guidance around, and why I'm passionate about it is that I really think it's an understudied, underfunded, and not well understood disorder, and it affects many, many people with cerebral palsy. It's difficult to diagnose it because there's many confounding issues that can present like dystonia and cause confusion around a diagnosis. Things like spasticity and acid reflux are some of the things that get in the way or that can be mistaken for dystonia. Medications, my son has gone through a variety of different treatments for dystonia, and they have been very harsh and not well tolerated. And I know many other parents in this community have had their children experience similarly failed trials. It negatively affects the lives of people with cerebral palsy and causes extreme stress for them and their families, as well as physical pain. And patients and families suffering from dystonia need your help to provide some clarity into treatment and diagnosis processes for dystonia. Next slide, Paul. So as a mom of a child with cerebral palsy, I spend a fair amount of my time in parenting groups, whether they be online or community-centered. I have a lot of conversations with parents who have similar questions about dystonia. Online groups, you can see various posts frequenting these sites around dystonia with questions from parents about what's going on with their child, looking for guidance, looking for instruction. Parents also question the accuracy of diagnoses. So they're questioning whether their child really does have GERD or food allergies or spasticity, or if this could perhaps be something else. And many of the parents in the community who respond to parents with these types of questions and suggest dystonia get responded to with a "what is dystonia?" meaning this is not a well understood disorder, and that many parents who are facing diagnoses of their children have not even heard of this or considered it as something affecting their child. So there's also a lot of questions around what the treatment options are and complaints about failed trials. And I myself can check each one of these boxes off as my experience as a parent. Next slide.
Okay, I think it's back to me. Thanks, Melanie. I really appreciate all your contributions, but also providing that community perspective. So what are we trying to accomplish with Research CP? What we're trying to do is determine what are the most pressing problems with dystonia and CP from your perspective, from the perspective of the community. So we got a group of us together that included a set of community members and a set of very committed clinician researchers. And we said, look, we want to engage the community from the outset. So from the very beginning, this has been planned as sort of a joint effort to get to these most pressing problems. And we've really reached out to a broad array of clinicians and clinical researchers to say, please get involved in this. We're going to work on setting this agenda, and we really want your input into it as well. And so really the goal is to establish a long-term set of relationships that will have like a very different type of interaction that can happen in the clinical setting and can really lead to advancing care for dystonia and CP. When we're done, we expect to have an output, which is this agenda that we will broadly communicate to the people both in the community as well as the clinicians, so that we think we'll be, potentially finding things that change standards of care or work on standards of care, as well as answering critical research questions. And we hope to drive the field to focusing high quality research on these questions, all with the intention of improving outcomes for people with dystonia and CP. So how do we go about doing this? Well, first, as we've said, we're engaging a broad array of community stakeholders. And the first thing that we do with Research CP is we try to educate everyone, so we are on a common ground of language. And so the webinar series, which runs for this month into the first week of next month. Starts with tonight's webinar, which is really intended to, give you a sense of how the whole program comes together, but really focus on a common language for dystonia and CP. Then the second webinar, which is on October 30th, is going to be talking about the standards of care in dystonia. And then the third and final webinar will be focused on what is the state of research and what are the known gaps in that state of research. So we've got a great team of people that have put together these presentations. We really hope you'll stay engaged in them and enjoy them. And so one of the things we do for engagement is at the end of watching the webinars, we ask you to take a short survey. Don't be worried that the survey is a difficult test. It's really intended for us to A, know that you watched the whole webinar, and B, reinforce the learning from the webinar. So the next way that this Research CP advances this set of goals is by creating this agenda. And we do this by asking what are the most important questions or what are the most important changes in outcome that the whole community views as important. And we're going to do this with a collaborative survey platform that's called CoDigital. And below here we have two screenshots that give you a little bit of an idea about what the CoDigital experience is like. It starts out and you actually go through and you add your ideas. And then when people come into it, they get presented with two ideas and said, which one of these ideas do you think is more important? And everybody, if you stay engaged, gets chances to add questions, edit questions, and then vote on them. And this iterative process results in a list of the most important ideas that will, generate a lot of votes. The last round of Research CP, we generated 26,000 votes and 392 ideas, but we really zoomed in on a top 16 set of research ideas, and CoDigital is the platform that we'll use to enable that. So what we're doing with Research CP builds on our prior experience with Research CP 1.0. And what we're going to run the CoDigital process a little different if you participated before, where we're going to run it for about a week and then stop and look at the results we're getting and then rejigger it. And we'll talk to you all about that along the way. And the way we're going to talk to you is using MyCP. So you signed up for Research CP Dystonia Edition on the platform or the web portal MyCP, which has several capabilities, but one of its main capabilities is it has a discussion board. And so you've all been joined to a group called Research CP, so we can hold discussions amongst ourselves to help understand the process and the priorities. And then in the end, the group is going to review this final research agenda through a discussion. We may do follow-on webinars, and that's how we'll get to this outcome of a research agenda. So just so that you are familiar with a little bit of this, so when you signed up for Research CP, you signed up probably either landing right on the join page, which was a questionnaire, or you may have come to the home page here. But if you go to mycp.org, you'll see these three buttons at the top. And if you click on sign in and enter your email and log in, you'll then see forum. And when you click on the forum, that'll take you to the MyCP forum. So you can see that it's just a standard discussion board. It's got the ability to discuss topics, and there are topics specifically dedicated to dystonia, Research CP Dystonia Edition. Our group, it's now over 100 people, but Research CP is an exclusive group. Other people can see the discussion, but only if you're part of Research CP can you join in this discussion. And then there is a category within so when you make a post, you can post in all sorts of different areas within the discussion group. But if you post in this Research Dystonia Edition, it is a posting that goes specifically to our group, and everyone will be informed about it. Similarly, when we get into the CoDigital process, there is this platform that you'll be interacting with, and it interacts with you partially with the platform and partially with email. So when we get into that, you should just be during the whole Research CP process, pay attention to your email, because we email you when there are things that you need to know about with a webinar. CoDigital will mail you so that you know that there are opportunities to vote on ideas. So it's very important that you pay attention during the initiative to your email and look for things from MyCP or CoDigital. And the forum on CoDigital the forum on MyCP actually will mail you updates about topics since your last visit, so you'll be able to see which things you need to engage in. So that's just intended to be a brief overview of of how the software platforms come together and allow you to interact with the whole group. So these areas in gray are the ones we've discussed. In the end, what we intend to do is produce a publication like we did for Research CP 1.0 that was published in a journal that's read by all the people that treat people with CP. And then we will use that agenda to drive the research questions and the priorities in dystonia research for CPRN, our big collaborative research network. And then ultimately, CPRN will measure improvements of outcomes for people with dystonia and CP over time. And that's sort of core to what our collaborative network can do and does do. So I talked about CPRN at a high level. Let me just give you a few data points. So it is a collaborative research network. So it's a set of clinicians and hospitals agreeing to work together to share data and to work on improving outcomes for people with CP. Currently, it's 25 centers across the US and Canada, and it involves multiple disciplines that treat people with CP. So neurology, developmental pediatrics, physical medicine, neurosurgery, orthopedic surgery, physical therapists, occupational therapists, all are involved. It has a data coordinating center that manages the data for it, for doing research studies and doing what are called quality initiatives, and that's all housed at the University of Utah. And we have that all stored in a registry, and there are two registries. There's a clinical registry that's capturing data from clinical care that's used to inform research, and there's a patient-reported outcomes registry, and that's actually embedded in MyCP. So if you've joined MyCP and you're either a parent or a person with CP, you can actually participate in research directly on that platform. And then as we've talked about with Research CP Dystonia Edition, CPRN has been patient-centered from its founding. So as the founder, I'm the father of a 14-year-old boy who's got spastic diplegia, and Michelle Schusterman from CP Now really engages a very broad set of community members in driving our work. So that's what CPRN is. So to just give you the timeline for the program, we've got the webinars that we're running in October into the first week of November. And then in November and December, we're going to do this idea generation and voting through CoDigital. And we'll be having simultaneous discussions in MyCP to sort of help tune the process, answer questions, make sure the CoDigital process is producing a meaningful research agenda. And then when we wrap it up and we're all done, the leadership team that's presenting all of the webinars is going to work on a paper for publication that we'll submit sometime in 2020. It takes some time to develop these papers, but that will aim at sharing the research agenda very broadly with the community. So you should expect in this November-December timeframe, we're going to be iterating a lot on educating you, generating these ideas, refining the ideas, and then stepping back and looking at our process and seeing if we have to make changes. And we may need to do a follow-on webinar to do some more education at that point, but we really want to just guide the process to producing a meaningful agenda. So that describes the process. It's good, it's a long time to ask you to be engaged. It will be, you will be able to do most of it at your own leisure. Engaging in CoDigital for maybe 5 minutes a day should be sufficient, or 20 minutes a week or something like that will get you really making a contribution. And then the webinars are recorded, so if you can't watch them at 8 p.m. Eastern time, you'll be able to watch them after the fact. So we really try to make it so that you can stay engaged and stay engaged at your own pace. So Next steps are you're going to receive very important links in email, post-webinar survey. It's very brief. It's 5 questions. It's not graded, but you do need to fill it out. There will be invitations coming in the mail to the future webinars just to remind you and to give you the links. We ask you to pre-register just because it allows us to manage the process. And then after the November 6th webinar, we will have the invitation to Co-Digital, where we'll be inviting anyone that watched all the webinars and is interested in participating in the idea generation and voting process will be able to participate. So if you're liking what you're hearing tonight and what we're doing, please continue to participate and take the post-webinar survey. So that's the overview for the program. What I'd like to do now is see if I can use the technology here to hand the controls over to Dr. Aravamuthan and let her take you through what is dystonia in CP.
Looks like
Bhooma, it looks like I see you moving the mouse. You've got control.
Okay. Perfect. Can everybody hear me?
I think they can.
Okay, great. So thank you very much for letting me talk about this topic that I'm very passionate about. What is dystonia is a hard question for any of us to answer, to be honest. And even as a medical practitioner who takes care of children with cerebral palsy and dystonia, it remains difficult to identify and to explain. So thank you very much for giving me the opportunity to talk about it today. So dystonia, just breaking it down, means abnormal tone. This means abnormal. Tonia refers to tone. It is a form of hypertonia, so that's high tone. And there are 3 basic subtypes of hypertonia, of high tone, that we think of. Spasticity is probably the most common form of high tone that we see in children with cerebral palsy, and maybe a form of high tone that everyone is more familiar with, medical practitioners, people with cerebral palsy. Dystonia is thought to be less common, but maybe a little bit more common than we think, and I'll get into that in a little bit. The last form of high tone that we see is rigidity, and I'm not going to talk about that very much today because it's very rare in children, but just including it here for completeness. Spasticity is really defined medically in terms of the exam, as opposed to dystonia, which I really think requires a lot of history taking to really understand, is dystonia something that's a part of your high tone picture. Spasticity is defined as resistance to stretch, passive stretch at a joint. So if I were to flex your arm very quickly and flex it very slowly, tone that increases with increasing speed of stretch is defined as spasticity. Spasticity is often associated with injury to fibers that come down from the brain, down through the spinal cord, and control a lot of our reflexes. These connections are called upper motor neurons. And so spasticity together with hyperreflexia is commonly seen, to the point where if you see high tone and then on exam also get fast reflexes, so a really brisk knee jerk, for example, spasticity should be something you're thinking of as a component of that high tone. Dystonia is different. So the other key feature of spasticity is that it tends to stay stable throughout the day. It's not particularly variable, and it's not necessarily triggered or worsened by certain activities. Dystonia, on the other hand, tends to be worsened or triggered by attempts to move, by voluntary movement. And when it is triggered, you get an unintended activation of muscles that you weren't trying to activate in the first place. The other aspect of dystonia is that it has increasing magnitude, meaning that it worsens with arousal. So the more awake you are compared to asleep, the more agitated you are. For example, if you're in the midst of an illness or you have a lot of pain or discomfort from something else like constipation or even severe reflux, sometimes you can have the dystonia that you have inherent when you make a movement gets worse. So just to break down those key features of dystonia, the quote that we most commonly use as practitioners that take care of children with dystonia is that there's overflow muscle activation. And that really means that you're activating certain muscles without meaning to. This is typically triggered by voluntary action, and dystonia does get worse as a defining rule with movement. But you can also have dystonia at rest. So it doesn't mean that you have to have completely low tone at rest. You can have evidence of this overflow muscle activation, unintended activation of muscles at rest that then gets worse with movement. And then, like I said, it varies with arousal. So one of the key features of dystonia is that it's not static. It changes with how you're feeling. It changes with how awake you are. It changes with whether you're moving or not. So it's a very variable form of tone where spasticity is thought to be more constant. And just to recap of that, so your tone is increasing with voluntary movement, and it's increasing with increasing arousal in dystonia. This is a flow chart that many of us use to try and differentiate subtypes of cerebral palsy, and this is from the Surveillance of Cerebral Palsy in Europe group, the SCPE, a well-known paper from that group from 2000. And I just want to highlight that one of the key ways that they suggest differentiating between predominantly spastic CP and dyskinetic CP, of which dystonic CP is a main form, is whether the tone is varying or not. So again, just highlighting how that variability is a critical diagnostic feature. There have been other epidemiologic studies that have suggested that spasticity in CP, or spastic predominant CP, is more common than the dystonia predominant CP. And I would say overall that's true, that spasticity does tend to be seen more. But I want to pose to everyone that maybe this is a forced dichotomy, and perhaps there's a lot more overlap than we tend to give credit for. This is an example of that overlap in a series of children with what's called secondary dystonia, meaning that they had some sort of brain injury or disturbance in brain development that led to development of dystonia. I've drawn arrows by what most people would agree are common causes of cerebral palsy. And what I want you to take away from this is that in at least a third of children with dystonia, that spasticity is also present. So that was by report and medical assessment looking at records. But if we assess the patient in front of us with objective scales and with exam in the moment, this is a study by Darcy Failing's group. You can see here at the bottom, these circles each represent proportions of children with dystonia and spasticity, and this section here is the lower limbs, and the section up here is the upper limbs. And in children that have dystonia in the lower limbs, you see that almost all of those children also have spasticity in the lower limbs. And I bring this up as an important feature because spasticity and dystonia can be very difficult to differentiate, and that difficulty in differentiating can often lead to a delay in diagnosis. So I want to hand off to Melanie to talk about an example of that.
Hey, thank you, Bhooma. Can you hear me?
Yes.
Okay, perfect. So bringing in some additional community perspectives, we bring in an example of a gentleman named Sean. Sean has cerebral palsy. He also has dystonia, but he was not diagnosed with that until nearly age 20. And that was 17 years ago. So he's been living with dystonia for quite some time. And majority of this time, his diagnosis has been unrecognized. And by the time he had officially received his diagnosis, this disorder had significantly impacted his life. It was affecting everything from eating and sleeping to even sitting comfortably or personal care, also affecting his emotional well-being, as anyone who's ever lived with pain can identify with. And it also limited his mobility in that he could no longer drive his wheelchair or use his computer. Two very unfortunate circumstances. Sean also, as with many people living with dystonia, had several failed attempts at medications to treat his symptoms. Everything from baclofen pumps, to other medications, and really affected his quality of life as well. His mom expressed that his primary concerns are the side effects of baclofen, which have negative other consequences such as impacting swallowing. And there are significant concerns shared among about his mental health as he continues to age, dealing with dystonia and CP.
Thanks, Melanie. It's hard to hear because it's out there and also because of how common it is. I think there is often a delay in diagnosing dystonia because of how hard it can be to differentiate from spasticity and how hard it can be to identify. So I just want to get into a little bit about how, by consensus, we classify dystonia. In the last 10 years, a little bit older than that, the classification nomenclature has changed. So historically, and you may have noticed that in one of the papers I presented, they talked about secondary dystonia. So historically, we used to classify dystonia as primary versus secondary. Primary meaning that there was a genetic etiology for the dystonia where the only symptom you had was pure dystonia, and you had no other associated symptoms, nothing else affected. The secondary is you had some sort of brain injury or neurotransmitter imbalance, for example, that led to dystonia and typically had other symptoms that were associated with that. Though this isn't a very clean split to the new definition, new classification of isolated versus combined, we think of isolated as people that have just dystonia and no other associated features, and combined as people that have dystonia plus other associated features like seizures or intellectual disability or a spasticity. So I just wanted to get into that verbiage because I think the transition in the literature is happening, so I want to make sure that we're all aware of it as well. There's also a view in the literature that I think can be even more confusing, which is a term called spastic dystonia, which is tough to define and has caused a lot of controversy. But I think when you see spastic dystonia, the overarching consensus of the field is not that it's a third overlap form of high tone, but instead represents what I've talked about already, which is that dystonia and spasticity, particularly in children with cerebral palsy or in people with cerebral palsy, tend to happen together. And when you see that sort of overlap, it can be difficult to differentiate between the two. But I think most of us feel that there is no need to add to the confusion by adding a third term for the overlap, and instead that it's just indicative of how often these two forms of high tone happen together. So dystonia does have some very classic positions that go along with it. But like I said before, it's very, and I want to show you pictures of those positions, but it's very difficult, and I would say kind of impossible to diagnose dystonia without having those other key features on history, namely the variability and how it's triggered, and by observing some of those features on exam. So even though these pictures show positions that are typically associated with dystonia, I don't want you to think you can diagnose dystonia with a picture, because that is not the case. One of the more common positions are what you see here with arm backward extension and typically an internal rotation. Another example, and this is probably one of the more common examples that we see in clinic, and something that can often be confused for spasticity, is this sort of positioning of the foot with the foot turned in. And you see in the first picture here that this toe is tonically up. That is a relatively rare, that toe being constantly up, a relatively rare phenomenon compared to the foot interning and the arm going backwards. It's called a striatal toe. And the reason it's called a striatal toe is because it's classically associated with injury to a part of the brain that we associate with dystonia. And as such, this type of toe that is tends to go up with attempted voluntary movement or with stress or increased arousal, we think of as an example of dystonia as well. And this position, called a cystotonus, is back arching. This can be very difficult to interpret. It is commonly a form of dystonia that we see, particularly in children with generalized dystonia, or children that are predisposed to having prolonged, debilitating periods of snowballingly, increasingly worse dystonia called storming. We tend to see this position a lot in those children. But you can also get back arching with reflux, for example, and I think Melanie mentioned that earlier, how it's difficult to differentiate what back arching is dystonia and what back arching is reflux. And I think that can be made even more difficult in that the discomfort from reflux can actually also trigger dystonia. So I think the key ways to think about it are to go back to the history questions that I talked about earlier. Do you see that back arching with attempts at voluntary movement, or are you only seeing it with feeds and in the middle of the night, let's say, when continuous feeds are going? Are you seeing that back arching triggered by any sort of illness, or are you only seeing it in relation to potential discomfort with feeds? And sometimes even with that history, it can be difficult to differentiate, but going back to those original history questions can really help. The key problem that I've gone over a little bit so far is how under-recognized dystonia is and how difficult it can be to differentiate from other types of tone. In this paper, they discuss how we feel very confident that we can differentiate between these different forms of cerebral palsy, but that medical practitioners have a lot of variability amongst ourselves in how we differentiate these forms of tone. Spasticity, dystonia, and in this case, ataxia and cerebral palsy. So this is just an example from Washington University where I am, and it's a chart review of children that all had hypoxic ischemic encephalopathy and underwent cooling for neuroprotection. And all of these children are followed up in our neurology clinics, and this was over a 3-year period that we studied this. And you can see that many of these children who had hypertonia would have had either spasticity or dystonia, but only a small subgroup of those children actually had that hypertonia defined as dystonia with or without spasticity, or spasticity with or without dystonia. And that the majority of children had hypertonia that never went classified. So I just want to highlight that even in trained hands at one of our large critical center or clinical centers, that it can be difficult to differentiate between these two without repeated visits and really learning more about the child and how that tone is evolving. Another example of that is the delay to diagnosis. So children with cerebral palsy and dystonia, though they can have the same age of dystonia onset as children that have a genetic etiology of dystonia, it often takes much longer to diagnose dystonia in a child with cerebral palsy than it does a child with genetic etiology of dystonia. So the average was 8 years after the onset of symptoms were first recognized by the family. So I think one of the goals in talking to you all about this is to try and come up with ways to close that gap and see if we can diagnose dystonia earlier. So thank you very much. I am happy to take and discuss questions.